Dr. Spalding, and this is a presentation on the Episealer implant in the knee, essentially focusing on the surgical technique and the clinical outcomes, but I also want to go through some of the background information and discuss the role for this treatment option for our patients. I'm a knee surgeon based in Coventry and also the Cleveland Clinic in London. My disclosures are here, and I'm on the medical advisory board for Episurf. So I think we have to recognize what the problem is, and that full thickness cartilage lesions do not do well and may progress to leave a patient with significant osteoarthritic change in the knee. And then the cartilage repair procedures are not so good in this middle-aged patient. So there is a gap in our treatment options. The background for this is that patients with focal cartilage lesions will have symptoms that can be as severe as those with progressive and bad osteoarthritis. So this can create quite an impact with the patient, and this has been shown in the previous literature. So there is this treatment gap essentially between the biological techniques at one end of a spectrum and the partial knee and full knee replacement at the other end of the spectrum. So there is a demand for this in the active patient with an active lifestyle. They want something with short rehabilitation times, and they want something with predictable results and a focal lesion in the knee. The principle here is to replace the pathologic cartilage and the subchondral bone with a metallic implant that will then restore that joint congruity and make a smooth articular surface sealing that area. Now, there have been different expressions for this and different names for the procedures, from focal anatomic resurfacing, and you see them listed here: condylar resurfacing, partial resurfacing, and then focal articular prosthetic resurfacing. But essentially, we're grouping these together as the mini metal implants. There are existing implants already. The hemicap was reduced in 2003, and then we have the biopoly, which is a metal base but a high-density polyethylene articular surface layer from biopoly. And then the Episealer, the product I'm going to be speaking about here, was introduced in 2013 for condylar and Trochlea resurfacing. The early experience with mini implants was mixed, and the hemicap was the first one out there to produce the data, and there were various series which unfortunately began to show that there was a 25% implant revision rate to arthroplasty. And in this registry from Denmark in 2013, then the survival rate at 6 years in 230 patients was only 45%. But that was a mixture of the hemicap and the larger unicap implant, and there was some information about what was on the tibia and how the joint surfaces were damaged in the rest of the joint. That was mixed. So at that stage, not such good data outcome. There are various challenges, therefore, that we need to look at for these mini metal implants. The surrounding cartilage must be able to accept and seal around the implant. And then we want the implant to be able to bond to bone. And finally, the implant must not damage the opposing articular cartilage. The Episealer is this implant here. We have a polished cobalt chromium surface layer. We have a titanium undercoating layer, which has been shown to help with good fixation and good bone integration. And then we have a surface that will allow smooth articulation with the opposing side. There is hydroxyapatite coating on the titanium on the side, and that will help seal to the articular surface. And there is also hydroxyapatite outer coating on the undersurface and the peg to allow good osseointegration. There are still various challenges in solution, and I think some of the animal data is worth summarizing here. And I know this is quite a lot on the slide, but essentially it makes various points. The HA coating, we know, seems to attract the cartilage. And therefore, if the cartilage can grow onto the side of the implant, then we can get this sealing. So the speculation from this is that this will reduce synovial fluid going into the lesion, and that may reduce further deterioration of the articular cartilage. That HA helps ensure that rapid fixation to bone, and therefore we can do early movement. And the titanium undercoating will ensure long-term fixation as well. So we don't have to wait too long for this to seal. Now, the design, as you're going to see, is then based on the patient's own anatomy, and that will conform to the patient. It sits this 0.5 to 1 millimeter under the surrounding cartilage, and you'll see from the instrumentation that that positioning makes it less likely to damage the opposing articular surface. So the indication for this is for patients with a focal, chondral or an osteochondral lesion on the femoral condyles or on the trochlea that's causing pain and or disability. And the patient will usually have had a failed series of conservative treatments and is willing to undergo the surgery. We can undertake this on various locations using the Episealer as a solo or as a twin item. So the twin is larger. The solo item can be made for the trochlea with the curve in the appropriate position, or it can be on the condyle as a solo or a twin procedure to essentially resurface damaged areas in the knee suitable for that particular patient's problem. There are different sizes, and then the key part, as we're going to go on to, is the MRI scanning, which allows for appropriate size matching, and then these are supplied by the company exactly what we need, going up to a twin, which is 2 times a 25 millimeter diameter implants. So focusing on the process, we send the MRI scan to the company Episealer, and we obtain specific 3D sequences that then can be mapped and make this damage marking report, and that gives a proposed design and a detailed analysis of the actual damage in the knee. As a surgeon, then we accept that or modify the design, and then finally we get back the implant, the guide and the instruments, and that all comes together, so it's minimal extra kit. And if I just show that here on the side, you can see there's the minimal amount of kit that is then needed. So in a bit more detail, this is the online access to the program. So the scans are uploaded, and by clicking on the various parts you can then manipulate the knee and see the 3D guide that's going to be provided. And the MRI images are on there, so that by scrolling through we can see exactly what has been cut and moved to make this design, and you can slice through the knee to see exactly where it's going to sit. So this gives the surgeon the ability to analyze exactly what's going to be covered and see how it's going to be positioned. Just in a little more detail, here is that marking. So by using the various buttons we can take away or add various elements to it. The implant, where it's going to sit, we can see the subchondral change, and then we can put the guide on, orientate it around so we know at surgery exactly where that guide should sit and where it does sit, and then finally implant the device to cover exactly what we need to cover on the condyle. So this is the damage marking report. It can come as a PDF and be printed out and then looked at. So we see the damage marking, we see where the implant is going to sit, we see the scans on which it is based, the 2D sequences, and then we can actually understand what is going to be placed, the thickness of the metal that is being proposed, and that can then be altered. And that gives us the information to be able to exactly know what we're going to be getting for the patient. And then also part of this is considerations for the other part of the joint, as it's very important to have a good opposing surface to the implant. So once we have accepted that, we get the final design, and this gives us the orientation for the 3D guide that is then going to be used for implanting the device. And we can print out one large version of this, so at the time of surgery we can then reference where the guide is going to sit in relation to the trochlear point, the notch, or anywhere around the knee how it should sit, and we can refer to that during the operation and then implant the Episealer implant exactly where it is anticipated to go and where we need it to go. Now if we move on to the actual operation itself, the final design image is delivered with the implant, so that can be used, held to one side and married up to the actual anatomy as we see it. We check the kit, then it's a mini arthrotomy and the implantation, and of course then the rehabilitation afterwards. So this is the operation. This is a subvastus approach on the medial side, left knee, retractors in at the correct place, and then we can map out the area of damage on the medial femoral condyle, and then we can see where that's going to be covered. And this is the guide that fits nicely under the skin, and it really is very impressive how it just sits in one place and it can't then be slid. or moved from that position. It is held in place with 3 wires that come with the kit, and these short wires, 2 of them are in parallel, so the guide can be then removed and reapplied if we want to see the exact depth. So once again, it's marked and we know exactly where the implant is going to be sitting. So this is the guide then for the drill. The first inner sleeve is applied and this starting hole is then fashioned, which is the starting point ready for the main milling, which will achieve the exact depth that we want. So once that is then removed, we insert the next guide, which then sits nicely in place, and it's marked in numbers 2, 4, 6, 8, etc. And what that does, it allows us to graduate the depth, and each mark is 0.2, 0.4 of a millimeter. So we have milled that area, and you can see now the crater, and then we have this trial, which is an epidummy, which we then sit in place, and that then holds there nicely, and we can feel around that area to see exactly where that sits and whether the implant is going to be covered. If it's not covered and it's not recessed to that 0.5 of a millimeter, then we can dial in a bit more, use the mill, use the drill, and let this sit down a bit more. It's very important that this achieves 0.5 of a millimeter or so below the joint surface. In this case, we're using the arthroscope to actually see that depth and give a better picture. So we've marked the top, ready for the implant, and then clean up the edges slightly. Once again, a final check with that epidummy to see exactly where it sits, and then taking the implant, which all comes together, then the implant can be put into place. There's a small little mark at the superior part which matches up with the damage marking, and then it's impacted into place using a customized device just to push it into place. And that sits there nicely, just that 0.5 millimeter below the joint surface. If there's any rough edges, they can then be removed, but essentially we're very pleased with that outcome, implanting it just 0.5 millimeter below the joint surface. Using the subvastus approach, that allows for easy closure and not interfering with the vastus. So the instrumentation really allows this very accurate positioning, and we can achieve this ideal of being just below the joint surface, not too proud, and just settled in the position that we need. For the larger area, this is the twin defect. This is a twin 20, and therefore the guide comes as more of an oval, and we turn round the interior guide that allows then separate drilling to make this oval shape. You can see how the guide sits where we want it to sit, and then the epidummy is slightly different. And once again, we can view from the window at the top of the guide or on the actual guide itself, just to see how that is settling. Once that's in place, we can remove the outer guide and then finally come to implant the twin implant, once again impacting it into place, and then finally removing those guide wires. So that's for the twin technique. Post-op rehabilitation, initially slow, 2 weeks touch weight bearing, then building up to full weight, usually by 4 weeks, a free range of movement because we don't want to get any joint stiffness, and then strength work once the knee is settled down at about 8 weeks, and really in the long term recommending avoiding heavy impact on the knee. Trochlea, of course, which is not taking load when the knee is in extension, then could be managed with full weight bearing and potentially using a brace initially to avoid overloading of that anterior knee part. So if we look now at some of the evidence, there's been some extensive preclinical work and then a growing number of clinical outcome data, and I just want to focus on some of that. Particularly, we're focusing on our recent publication with 80 patients as a consecutive series published in 2020, looking at prospective data collection with 24 months outcome for focal defects, ICRS grade 3 or 4, who had tried conservative treatment and fulfilled the criteria and the indication. So this is a single lesion on the femoral condyle or on the trochlea with intact, good quality tibial cartilage and normal leg alignment, and it's that is an important consideration on the indications. So we've collected demographic and surgical data and outcome scores at the time points there, 12 and 24 months. And we have the KOOS and the visual analog score. So we have 75 in that cohort to analyze. 2 have been revised, 1 declined to stay in the analysis, and then 2 have got incomplete data, so have been excluded from this analysis. But essentially you can see that 59% are female, age mean is 48, and the BMI is in a reasonable range at mean of 28. 65% have had previous treatment, many of that being microfracture, some mosaic-plasty, ACI, so from failed previous articular cartilage surgery, so a slightly more difficult group. We've got 10 on the Trochlea, 25 twin on the condyles, and 45 solo implants, so 65 on the condyles. This is the outcome for the whole group, the KOOS domains and the visual analog score. And you can see the improvement over time with the different shading for the 24 months outcome from the pre-op outcome, showing an improvement in all the domains. And then on the visual analog score as well, pre-op 3 months, 12 months and 24 months, continued improvement but maintained from the initial visual analog score. When we look at the outcome by implant type, we don't have enough patients in the group to produce clinical significance between those. There may be a trend towards the trochleas doing well, which will be very pleasing, but we can't say that based on statistical analysis. But you see improvement in all the groups, 3 months, 12 months, 24 months. And also, when we stratify by the implant type on the visual analog score, again there is improvement. It may be that Trochlea is better, but there's not statistical evidence of that. When we analyze the group according to whether they've had previous cartilage treatment, it does appear that the primary cases appear to be better, but again this has not reached statistical significance, and we need more data to be able to answer that question. 2 patients have undergone revision. The first patient had a significant amount of bone marrow edema preoperatively and really had no improvement following the implantation. Pain was increasing, and this patient was revised to a unicompartmental knee replacement after that. Second case had previous OATS, once again had never been pain-free from any of the previous surgeries that we performed. The patient had subchondral cysts and a thicker implant was used at the time, but really never improved and underwent revision at 19 months to a more biological approach with bone grafting and then covering with the chondrocyte membrane. That is my patient, and I know that patient is now still doing well a year down the line from that revision surgery. We've had 1 patient with infection who was revised after the study period at 27 months, and we've had 2 arthroscopies for pain relieving scar tissue and mechanical clicking, and 1 DVT in the group. So the conclusion from the study point of view, then we know that partial knee resurfacing is not new, but we hopefully have built on the previous results, which were fairly variable. We've got a select cohort analysis of 75 patients at 2 years with a low failure rate of 2 out of the 80 failed, that's 2.5%. We've shown the good clinical improvement in the quality of life and the functional scores, and the individual design has been accurate. That depth and location has been easy to achieve using the 3D printed guide and the damage reporting and the instrumentation. So the next phase of any research work is to focus on the optimal indications, reducing that failure rate further and focusing on the gain in the quality of life. This is another series of prospective multicentre study just in 10 patients at 3 years, showing that improvement out at 75 months has been no revisions, 24 months no revisions, and then the clinical scores seem to be maintained at the 5 years with improvement in the visual analog score. So this is promising data out at this time in the very early series. So if we put this all together, then I think we can say here the indications for focal resurfacing in 2021, and this is what we need to then focus on. So we have focal lesions, the pane has to fit with the MRI scan, and the opposite surface needs to be ICRS grade 2 or less. And what that means on imaging is that there should be no loss of joint space on the PA30 views. So we need a good opposing articular surface. The meniscal volume should be 50% or more without extrusion and failure of that compartment, because once we see that extruding meniscus, then we have to accept that the compartment is failing and these mini implants will not do so well. We don't want deformities of the bone, we want alignment neutral, and we want a patient who is willing to undergo the rehabilitation and not want to just go back to impact activities. Clearly a good BMI, non-smokers preferable, and normal ligaments around the knee and no metabolic disorders to affect the bone quality. So to go with that, there must be contraindications. We want to keep this to focal defects and not generalized arthritis. We need good bone stock where it's going to be inserted, and these do not do so well if we've got bare bone on the opposing side. And they have a list here on the right hand side of the slide of the relative contraindications that would not be so good for this treatment. So take-home messages from all this. Very clear there is this treatment gap before joint replacement. Patients have symptomatic localized chondral lesions that have not yet fully developed osteoarthritis that need knee replacement. And so now we have a treatment option for this patient. The mini resurfacing implants, it is a feasible option, and we've shown the clinical benefit, and it really does have a good role therefore for certain types of patients with chondral defects or osteochondral defects in the knee. Essentially, this is a second generation mini implant that is anatomically patient specific with the instrumentation to suit and appears to have good healing features that allows for sealing of the defect, smooth articular surface, and improvement in patient function. With that, I thank you for your attention. I do acknowledge all the other authors in our study that have put together this data, and we hope to then produce 5-year results and going forward more results sub-analyzing the factors. Thank you very much.